so let's talk a little bit about prostate cancer. Prostate cancer is one of the most common cancers. It is the most common cancer in men, and in general, the second most common cancer after skin cancer. And whenever 6 men are in one room, one of 6 men is likely to develop prostate cancer if they live long enough. And you know, everybody, like, the chance that anybody develops prostate cancer increases with age. So being a male is the most important risk factor, of course, but living for a long time is one of the most important risk factors. Some studies show that patients who live till their 60s, 70s, 80s, 90s, the risk of prostate cancer increase. Does not have to be high-grade prostate cancer. This is why in most men who have who may die without knowing they have prostate cancer, they may have low-grade prostate cancer. Now, most commonly, the presenting symptoms, historically, the most common presenting symptoms have been urinary irritation. Prostate cancer used to grow to a point where it obstruct the urethra, so it becomes difficult for the patient to pass urine. But now, because we are doing a lot of PSA testing, the more and more patients just presenting with an increased PSA. So because of one of the most common symptoms is urinary issues, when a patient goes to the doctor with elevated PSA, of course they will order repeat PSA just to make sure that the elevated PSA originally was not due to infection, or is not due to, like, the fact that a patient had sex the night before caused the elevated PSA. Actually, many things cause elevated PSA, that, like ejaculation, anything that causes ejaculation, riding a horse, anything that irritate the area in the pelvis. So we repeat PSA, and then also they will do a rectal exam to see if they can feel anything with their fingers, and then the next common thing, logical thing, will do to do a rectal ultrasound to see the prostate, to see if they can see anything with the ultrasound, and then also to do a biopsy. In the doctor's office, you will also fill these forms. It's American Urological Association symptom score. Basically, it tells us how your urination. And you also fill these sexual function score. Tell us how at baseline how good or bad the sexual function is. And also you will do clinical staging. Basically, this is the finger exam I told you about. Basically, you put your finger inside the rectum and you try to see the prostate, which is like about 5 centimeters away from the anus, and then you can tell. Can you see, is it soft? Is it smooth? How big it is? Can you feel like any nodularity on the prostate? And if they see nodularity, is it on one side or on both sides? And they can also feel other things like if the cancer went outside the prostate. This is the rectal exam. As you see, the prostate is about 5 centimeters down, and you can measure on both sides, make sure it's smooth, it does not show any findings. After the rectal exam, you will now you have PSA, you have a rectal exam, and you can start, and you have a biopsy results. And based on these three, you can start putting every patient into a different risk category. So if the PSA is low and the finger exam did not show anything, and the Gleason score was not higher than 3+3, then overall your risk category is favorable or low risk. As these numbers increase, as the PSA increase, as the rectal exam becomes more suspicious, and as your Gleason score increase, you are jumping from low risk to intermediate risk, to high risk, or even very high risk. There is also staging for prostate cancer. We don't use it as much, it's not as useful, but basically this is a language that doctors use to communicate what stage the prostate is. Usually to speak about N0, meaning there is no lymph nodes, N1 meaning there is lymph nodes, the cancer spread to the lymph node. We also speak about the M category, metastasis category. Did it spread outside the pelvis? Did it spread to the lymph nodes but outside the pelvis? Did it spread to the bones? Did it spread to areas outside the bones? Based on the staging and the nodal and the nodes and the metastasis, then we can say this patient stage 1, 2, 3, or 4. And the last thing, as I told you, is a biopsy. When the doctor does a biopsy, they go through the rectum, and they usually do standard 12-core biopsy. So as you can see here, this is the prostate. If you're looking at it up front, this is the base, this is the apex, and this is the mid. So the standard would be to take 2 cores from the right base, left base, and 2 cores from the right mid, left mid, and 2 cores from the right apex, left apex. And then each of these cores will go to the pathologist, and the pathologist will look at it under the microscope and then will grade it. And this is the Gleason score. What grading means is that the pathologist will look at it, and pathologist, depending on how ugly it is, will give it a score or a number. If it looks like normal glands here, then the score is 1. This is not cancer. 1 and 2 is not cancer. But as the number increase, as the cancer gland look ugly, then you can give it higher score, 3, 4, 5. And this is what we get when we say Gleason score. Usually for low grade, for example, it is 3 plus 3. A patient with a 5 plus 5 or 4 plus 5 or 5 plus 4, this a patient has very aggressive cancer. So this put us on this slide, which is risk stratification. So at this point, the doctor have PSA, the doctor have the Gleason score, and the doctor have the results of their finger exam or the ultrasound. And then we start to stratify the patient into low risk, intermediate risk, and high risk. This is a very, very simplified diagram. Now we know that in the intermediate risk, there is favorable intermediate risk, unfavorable intermediate risk, and there is one new category probably called high risk intermediate risk. And in the high risk, there is favorable high risk, there is lethal, very high risk, and there is lethal cancer. So this stratification, I just wanted to keep it simple, just to give you an idea, like how the doctor is thinking about the patient when they see the patients. So now, now I finished with the just introduction, just to put everybody up to speed, and then now brachytherapy. Now I want to talk about brachytherapy. So is there any questions so far?
No, I think you can go on, Dr. Mohamad.
Okay. So now brachytherapy. Today, first I'll tell you a little bit about brachytherapy, but then brachytherapy, we just have to know that it's either used alone for the treatment of prostate cancer or as a support for the external beam portion, as a boost for the external beam portion. We use it alone for low-risk prostate cancer or favorable intermediate risk prostate cancer. And we use it as a support for external beam in high risk or intermediate risk or unfavorable intermediate risk prostate cancer. Let's talk about the history of brachytherapy. So this actually started very, very, very early on. The discovery, sorry, not X-rays, this is discovery of radioactivity was in 1895. Within a few years after the discovery of X-rays, people already started using X-rays to treat cancer. But the use of brachytherapy started somewhere between 1911 to 1913, where doctors started to notice that they don't need to use X-ray from very far away to treat the cancer. They can actually put the radioactivity material close to the cancer or inside the cancer in order to treat their cancer. And this started in 1913, but also developed very quickly in 1915. Let me show you a little bit what this means. So let's, for example, very early on, long time ago, this is the catheter. and this is what they are holding the radioactive material with. So what they do is they will put this catheter inside, for example, inside the patient's bladder. This will go into the bladder, and then when they put the tip of the catheter close to the cancer, and then they will bring this radioactive source all the way in, and they will put it near the bladder cancer in order to kill the cancer. And this is initially when they first started this radioactive source was made of radium. Initially, when they very started doing these techniques, you can imagine this is very, very, very crude technique, and the control of cancer with these techniques was not very strong. But this is not only related to the fact that the cancer was that the technique was bad, but it is also related to the fact that most of these patients at that time were presenting with very advanced stages. So you cannot cure cancer, an advanced cancer, with a technique that only treats locally. So at that time, there was no chemotherapy. At what time the treatment were only surgery. So you cannot treat an advanced cancer with these techniques. And the techniques were bad as well. With time, things developed. And now I will just tell you, like, at today, how we treat the prostate cancer with brachytherapy. So the first thing for prostate cancer, when a doctor sees a prostate cancer, they will be thinking about the risk stratification, which is basically the PSA, the digital rectal exam, the MRI, the ultrasound, the Gleason score from the pathology report. So once they have a good idea about the cancer, the doctor also look at the patient. How old is he? Does he have other comorbidities? Give you an example. If you have a low-risk prostate cancer, we know that low-risk prostate cancer really, in general, does not kill people. So if you have low-risk prostate cancer and you are 85 years old, or even 75 years old, or even 80 years old, but you have a lot of comorbidities. You have had a stroke in the past year, you have a heart attack in the past year. Most likely, the patient usually dies from other causes before a low-risk prostate cancer becomes a problem. So this is for these patients, we usually don't treat the prostate cancer. So just trying to give you an idea how the doctor looks at the patient. It's not only how the disease itself, how aggressive it is, how spread it is, but we look at other things. Now, if a patient is 65 and they have low-risk prostate cancer, then we talk to them about active surveillance or about treating the prostate cancer. And then it becomes a discussion, and many things will come into the discussion, including patient preferences, what they value most in life, how they are doing exactly like medically during that time, etc., etc. So one of the very important things for any prostate cancer treatment, including brachytherapy, is patient selection, and we have to be very realistic in patient selection. So there is an association called the American Brachytherapy Society. They have a set guidelines for patient selection. For example, there are some absolute contraindications for prostate cancer. For example, life expectancy less than 10 years. If you have a low-risk prostate cancer, but the doctor looks at you, and it takes me back to my thought before about you have to look at it as a patient as a whole. If we don't think you will live more than 5 to 10 years, then probably you should not get treated for your prostate cancer. For example, other patients, they have unacceptable operative risks, because in brachytherapy we will need to do some form of anesthesia, whether it's general anesthesia or whether it is like spinal anesthesia or epidural. You should be able to tolerate that. So if a patient needs a general anesthesia and they have like many cardiac issues or they cannot breathe, then probably they are not a good candidate for brachytherapy. Distant mets. If a patient's disease has already spread, then I would say 99% of the times they are not a good candidate for brachytherapy. However, things are changing now. We are doing brachytherapy for patients with distant metastases, but this is also debatable. Some people will say that this is unacceptable. Some people will we can start to defend it some way, but it is still early on to accept brachytherapy for patients with metastases. If someone does not have a rectum for whatever reason, like they have rectal cancer before treated with surgery, we cannot do brachytherapy because you cannot put the transrectal ultrasound, so you cannot see the biopsy. If someone have a large defect in their prostate because of prior procedures to the prostate, then you cannot put the seeds. There's also a medical condition called ataxia telangiectasia, and these patients are very sensitive to radiation. So not only brachytherapy, many other radiations are maybe contraindicated in them because they are very sensitive to radiation. Some other issues we have to be aware of, but does not preclude a patient from getting brachytherapy. If a patient have a very large prostate, for example, then you really have to consider your options when you are thinking about radiotherapy. Or if you have the prostate is bulging into the bladder, think about it. During brachytherapy, you are putting needles in the prostate. When you put the needles in the prostate, you don't want to poke into the bladder. If the prostate is bulging too much inside the bladder, then probably there is a risk that you are putting needles in the bladder, or you are delivering a lot of radiation to the bladder. So the doctor have to be very careful. Also, inflammatory bowel disease. This is a disease where your rectum and your bowel in general are very, very sensitive also. You don't want to irradiate these patients who have active inflammatory bowel disease. If your inflammatory bowel disease is not very active and you need some form of radiation, probably brachytherapy is better than external beam. Okay, so these are general patient selection criteria. Now, with respect to prostate cancer, which patient gets brachytherapy alone and which patient gets brachytherapy in combination? So the American Brachytherapy Society give these general guidelines. Here you have low risk, intermediate risk, high risk. Here you have brachytherapy alone or combined with external beam. For patients with low risk, probably you only need brachytherapy alone if you're getting treated for prostate cancer with radiation. For a patient with high risk, you have to get brachytherapy alone is not enough. It has to be combined with external beam. For a patient with intermediate risk, the jury is still out, and this question is being addressed in some clinical trials. And I think you can justify brachytherapy for favorable intermediate risk, and a combination of brachytherapy with external beam for patients who have unfavorable intermediate risk. So for every risk category, there is brachytherapy can play a role in the treatment of prostate cancer. So let's talk about some vocabulary. You will hear for prostate cancer, you will hear a lot about, especially here in the clinic, every time the patient comes to me, and they always speak the most common language they use, the most common word is seed radiation. But there is, when you say seed radiation, it's not very clear, because there is permanent seeds, where the patient leaves the hospital after their procedure and the seeds are still inside, and there is transient seeds, where the seed goes into the prostate but does not stay. It just moves through a prostate and delivers the radiation, and then by the end of the procedure, the seeds stay in the hospital after the patient leaves. And this depends on the rate of delivery. So if you put the seeds inside, this is called low dose rate, or LDR brachytherapy. If you are using high dose rate radiation, then the seed is transient. You don't want to put a seed for a long time with high dose rate radiation. You will injure the prostate, you will cause a major problem. So we just remember that whenever you speak about seed radiation, you have to clarify, is it permanent seed or transient seed, or is it LDR or HDR? So let's talk about LDR technique. So this is the setup is very similar. You are putting I don't know, 14 to 16 needles through the perineum while you are looking at the prostate, because you have the rectum, the ultrasound in the rectum, you are seeing the prostate, you put in 15, 16, up to 18 needles, but not more than that. It's somewhere between 12 and 16 usually. And I will show you a picture in a second, the whole setup. Let me go to the picture and then we can talk about this. So this, you can imagine the patient perineum will be here in this area. And this is the rectal ultrasound. It will go into the rectum, and this is called a stepper. And there is a knob here. This knob here, you can, every time you rotate, this ultrasound will go into the rectum. So as you can rotate in and out, and this ultrasound will give you a full picture of the prostate while you're doing the procedure. This is the template. You see here A, B, C, D, E, F, G, 1, 2, 3, 4, 5, 6, 7. And so the doctor will put needles into, there's openings along this grid. The doctor will put the needles through the grid, and then it will go through the skin. Oh, sorry. And then will go through the skin, and it will go into the prostate. And everything is under live imaging of the prostate. So this is a grid. You eventually end up with, like, let's say 14 needles. They will be all here. And after you are done, you put the needles. This is called the MIC applicator. The MIC applicator will sit on each of these needles and will start inserting seeds into each of these needles until you are done with all the 16 needles. This is the LDR technique. These seeds stay inside. They don't come out. And these seeds, depending on what source you are using, you can use, some patients will say they want to use, most of the time the patient does not choose what they want. Usually the doctor chooses, but occasionally I have a patient that say, oh, I heard about cesium, so I want cesium instead of iodine. And the studies have shown that whether you use cesium or palladium or iodine, in general, they work the same way, but they do have some differences in their side effects. In general, the side effects of this technique is you have worse. So what happens is you put these seeds, there's suddenly a lot of inflammation and swelling in the prostate, and the prostate will swell. When the prostate swells, it compresses on your urethra, making urination more difficult. So you will wake up more at night to urinate. You will wake up, you urinate more during the day. You may have some pain with urination and some bleeding with urination. One of the choices, one of the things to consider when the doctor chooses what source they will use is what does the patient prefers. Oh, I'm hearing a lot of okay, now it's better. So with iodine, for example, the side effects are slow, and they last for a long time, but they are milder than cesium. Cesium, the side effects are more intense, but for a short period of time. So basically, this is usually the doctor picks. But if a patient, give you an example, cesium, it decays much faster. I had a patient in the past who came to me and he said that, very interesting story. He said that he wants his seeds to decay before Easter, because he usually is the Easter bunny, and he works in the mall, and as an Easter bunny, he takes pictures with all these kids who will be sitting on his lap, and he did not want to be sitting with radioactive seed inside him, which made a lot of sense. So we did cesium for him instead of iodine. Most patients don't have that issue, but it was I will never forget that the patient that this actually happened. So after we are done, we take we put all these seeds and we take a picture. You see, this is a picture. This is an X-ray because we want to confirm the location of the seeds. So we take an X-ray. These are the bones of the pelvis. This is the pubic symphysis, and this is inside the bladder. And you see the seeds are aligned. It's nice. And this is the prostate. And this is the last picture, probably. Typically, maybe I think there's like about 40 seats here. And sorry, I just got a page. Do you mind I come back and give me 3 minutes?
Very good. Okay, go ahead, Doc.
I apologize. Just 3 minutes.
Oh, okay. While we have this short break, let me just tell you that the reason I went to these guys, not because they do these permanent seeds, but because they do the temporary seeds. And he's going to go on, they do the temporary seeds in San Francisco. And the reason I went there is because a couple of years ago, I was at a PCRI conference and I heard Dr. Demanis talk about HDR brachytherapy, and he showed on the slides, he compared the results of short-term or HDR brachy versus other kinds of treatment, and seemed like the very best results were this combination of HDR brachytherapy plus external beam radiation. But this is this is done much more commonly. The permanent seeds, like you said, have been around forever. And you can get them here in Cincinnati, or you can go to Dr. Merrick in Wheeling, West Virginia, or to Dr. Zatoli in Sarasota, Florida. There are lots of places to go to get permanent seeds. He's probably going to talk a little bit more about the sensitivity of prostate cancer to radiation versus other tumors, other kinds of cancer. And there's some evidence that prostate cancer responds very well to very high doses given all at once, very high dose rate radiation. I hope he does talk a little bit about the radiobiology of the cancer. And so I read about that and I thought that, and after listening to this presentation by Dr. Demanis, I thought, you know what, the evidence to me seems pretty compelling, and that's why I decided to go with HDR brachy. There are a couple of other reasons why I chose this. Before this, I had focal laser ablation, and that created a lot of scarring in my prostate. When you get these seeds, the radiation causes more powerful changes to the prostate.
Yeah, we're ready. Go ahead.
Yeah, so this is the last picture. So after this is done, typically the patient usually goes home the same day. 95% or 99% of the time, unless they start with lots of urinary issues, they go home without a Foley catheter, and they come back 1 month later to do a CT scan to confirm that none of the seeds migrated to a different location. And this is LDR. This is low dose rate. This is LDR. This is permanent seeds. Now the other one is HDR. Remember, I told you HDR. You put the needles inside, or the catheters inside, and then you connect these catheters to this machine. And this machine, very thick metal. It has a smaller than a grain of rice. It has a seed made of iridium-192, and that seed is attached to a wire. After you put the needles in the patient or the catheters inside the prostate, you connect each of these channels to the channels that are poking out from the patient, and then what happens, and then you leave the room. This has to be in a shielded room, and then based on your treatment plan, this machine will send the seed into each of these channels and will deliver radiation to the prostate. At the end, that seed will go back and be housed inside this afterloader, and this is called HDR. It is the HDR versus LDR. There are lots of similarities, but lots of differences. I'll give you an example. HDR is a little bit newer than LDR for prostate cancer, at least as a monotherapy. HDR, upfront, the cost of HDR is high. You need to buy this machine, you need to have a shielded OR, but however, this machine and the shielded OR, you can use them for different techniques. You can use them for this kind of brachytherapy for prostate, but also you can use them, for example, for gynecologic malignancies like cervical cancer or uterine cancer. In LDR, upfront, you don't need a shielded room. You can do it in a non-shielded room, but you cannot use these seeds are specifically used for the prostate cancer. The other thing with the LDR versus HDR is that the LDR, when you put the seeds, then that's it. You cannot change their location. You have to accept where you put them. So it is very operator dependent. You have to be very careful. The doctor needs to be really good about them. With this one, the technique is more forgiving because there's no seed that will stay inside. There is no migration of seeds. You can control the location of your seed. Then it is much easier to treat using this seed, using this technique. So this is HDR. So let me show you this couple of very busy slides, but I just want to give you an understanding of what the doctor are looking when they do a treatment plan. So just give you an example. You come in for an HDR technique. We put the catheters in, and we do the scan. And now the patient is waiting in the room while the doctor is doing this treatment plan. Basically, the treatment plan is this is our way of telling the machine, the afterloader, to deliver the radiation to the prostate, giving the highest dose to the prostate, while at the same time giving the lowest radiation dose to the urethra and the rectum. And this is part of what we call treatment planning, and we have to respect the constraints. Basically, we talk about D90, V100, V150, and many other constraints. There's nothing for you to learn except the fact that this is how the doctors communicate when they are trying to talk about the treatment plan for every patient. Now, so we spoke about radiation therapy. Let me give you just one thought about when we do radiation therapy for early stage prostate cancer. I told you it could be delivered with LDR or HDR. LDR usually is one visit to the hospital. You put the seeds and you go home. HDR, it's usually 2 visits or more. The studies that have looked at one visit for HDR, apparently it is one visit is not enough, but we are not really sure if we can optimize that in the future. As far here at UCSF, what we do, the patient will come in the first day, we put the catheters in the morning, we give them the first radiation in that day in the afternoon, and they stay overnight with the catheters in until next day, and they get the second treatment in the morning next day, and they go home. And this is one of the main advantages of LDR or permanent seeds over HDR, because with HDR it's 1 day, with LDR it's 1 day, with HDR for monotherapy you have to stay at least overnight. Many other places are still doing these treatments over four treatments rather than 2 treatments. But it just depends on like the workflow in every hospital, what the doctors are comfortable with. Now, we've spoken about LDR and HDR for early stage prostate cancer, whether low risk or favorable intermediate risk. For unfavorable intermediate risk or high risk prostate cancer, LDR or HDR or brachytherapy in general alone is not enough. So you have to combine it with other treatments. And so the other treatment usually is hormone therapy, of course, but also external beam. So this is the next topic, which is the combination therapy. There are many studies which have compared external beam alone or external beam plus brachytherapy. I will talk about the ASCENDE-RT, which is probably the most cited study that has been done in the past 5 years. So in the ASCENDE-RT, they compared external beam alone versus external beam plus low dose rate brachytherapy boost in patients who have intermediate risk and high risk prostate cancer. And they had about 500 patients in this study. And so almost everybody got 12 months of hormone therapy, and they were divided into two groups. One group received only external beam, and one group received external beam and internal beam. And what they found out is that all people on both arms of the study, they lived exactly the same amount of time. So the addition of brachytherapy boost did not make these patients live longer. So this is very important to understand. Giving a low dose rate brachytherapy does not make the patient live longer. If you see here, these are the survival curves, whether you get the red, which is the boost, or the black, no boost, they survive exactly the same length of time. However, they found out that patients who receive the boost, they have undetectable PSA for a longer amount of time. Whereas those who had the external beam, they started to have increased PSA at an earlier time point. So what we are doing here is that we are giving an aggressive therapy, which is the boost, and not making the patients live for longer time, but we are giving them longer time of suppressed PSA. However, what makes it a little bit more challenging is that the patients who had the boost treatment here in red had more genitourinary and gastrointestinal toxicities from this treatment. Most of these toxicities, for example, give you an example of one kind of toxicity. At 8 months after radiation, the patient was having difficulty with urination. So what happened is that they went to the urologist, and the urologist did a scope, and they found that there is a stricture inside the urethra. They had to dilate the stricture. This is one example. So they found out that much more, 3 times more patients were having toxicity from this treatment compared to the external beam only. So this brings us to the very important question is, you have this treatment, you are not making the patients live longer, and you are giving them more toxicity, and how do you justify the treatment? Now this is a very, very, very long discussion and debate in the community between urologists, radiation oncologists, and everybody is either with or against. But I'll give you like the thought process for each. So although those who defend brachytherapy boost, they say the following. They say, although I don't make them live longer, but we believe that this study did not follow the patient for a long time enough. Maybe if we follow the patient for a long time enough, you see the benefit with overall survival. And also, although they don't, even though they don't live longer, there is a PSA benefit. Think about it. If these patients here, their PSA started to increase at 3 years, 4 years, then they will have to undergo all the studies and imaging and scans, and they may need additional treatments, and they may need additional hormone therapy, which is very important to consider, because if I save you a little bit of toxicity in the beginning, I may be giving you more toxicity from further treatment later down the road. So it's always a balance between the toxicity that you will accept upfront versus the toxicity that, or the decline in quality of life that you may have later. The other thing is that many people criticize this study that they had their toxicity was unacceptably high. People are saying, I don't know if that's true, that a lot of the doctors who treated on these patients, because they used the low dose rate, the permanent seeds, probably they put the seeds in some location that the seed migrated, and the migration of the seeds closer to the urethra caused this toxicity. At UCSF, we don't do low dose rate, we only do HDR, and our toxicities are not as high. And as you can see from these studies, these are the genitourinary toxicities and late gastrointestinal toxicities. The ASCENDE-RT, we are here, 18% for GU toxicity, 8% for GI toxicity. A lot of the studies don't have these high numbers, but this is something every institution have a different thought about this, and every doctor have a different thought about this. Here at UCSF, I work with Joe Shu, who was the national PI on the study, RTOG 0321. Basically, this is a single-arm study where patients got external beam and HDR boost. This is exactly the kind of treatment we're doing here. The study had 120, and this study is not published yet, just presented in ASTRO in September. These patients there was 129 patients, median age was 68, and the patients did very well. Almost half of them got hormone therapy, and the toxicities were much better than what was seen in the prior study that I have shown you. Most patients lived for a long time, and the failure rate was much less, was very acceptable, which is 10 to 15%, which is very good. So this is exactly what I was telling you about this debate between, do you do only external beam or you do external beam and brachytherapy together. Some patients, some physicians are extremely passionate about this debate. Basically, it is unclear what is the best option, and definitely for sure, there's no one size fits all. Every patient is different. Every cancer is different. When you put the patient and the cancer you get together, you get unlimited possibilities, and every patient should be assessed individually. Now let's go to talk about very important topic, which is cost effectiveness. For patients who receive brachytherapy alone, if you have a low-risk prostate cancer or a favorable intermediate prostate cancer, prostate brachytherapy is the cheapest option for your treatment. So it is even cheaper to do prostate brachytherapy than to do active surveillance. Because think about it, with prostate brachytherapy, you get the brachytherapy, and you are done. You pay for the brachytherapy, whatever it costs. Here it says $35,000, and you go home. For active surveillance, you are getting a biopsy every year, you're getting MRI every year, you have the PSA and doctor visit every year, and typically about 30 to 40% of the patient will need some sort of treatment within the first 5 to 10 years. So eventually, it turned out to be that brachytherapy is the cheapest among all the options for treatment of low risk or favorable intermediate risk prostate cancer. The last few slides, I'm almost done. I just want to show you some of the pictures we deal with when we are doing a case review. So this is when we do the treatment planning here. The yellow is for bladder, the red is for prostate, the blue is for rectum. This green thing here, this is for urethra, and you can see these dots. These are the actual needles that are inside. So basically, we do a 3D rendering of your anatomy on the inside to see exactly what we are treating. And here you see this is the prostate in green, and each of these lines is a dose level. So we try to push the dose away from the bladder. You can see the dose is carved away from the bladder. And here we try to, this is the rectum here, we try to push the dose away from the rectum. And these are some paperwork that we are trying to fill every time we do. And the patient usually leaves the hospital with these two forms. Basically, one form saying like this. One form is to give, for example, if you go through the airport, if you have radioactive seed in you, we give you a form to say that you have radioactive seed. And at the end of the procedure, we make sure that you urinate before you go home, and we make sure there's no blood clots. And if you cannot urinate, usually go home with a Foley catheter. You come back within 2-3 days to try to remove the Foley catheter, and you take Flomax to help you urinate. And usually the pain is minimal. I usually don't prescribe any pain medications, but usually we tell the patient to take Advil or Naproxen or whatever pain medication they usually take. Pain is not really that much of a big deal after the procedure, and you follow up with 1 month to check on you. And that's it. Thank you.
All right.
I have time for questions.
Okay. How shall we do this? So, does anybody have a question? Okay, that's Mr. Preston back in the back.
Yeah.
Okay.
And brachytherapy be used on one side of the prostate if the cancer is localized to one side?
So, sorry, is that question done? I'm sorry.
It's about focal brachytherapy. Can you do focal?
So now we don't do focal brachytherapy. So if a patient comes in and they have never been treated before, we don't do focal brachytherapy. We treat the whole prostate now with the thought that usually prostate cancer is not limited to one area. It's actually limited to, it is probably present throughout the prostate, and you cannot like treat one area. However, now with us using a lot of MRIs, and we can see that many times the MRI, many times the whole prostate on the biopsy, the whole prostate does not have cancer except the lesion on the MRI. I would not be too surprised if we start to see some people having only on clinical trial doing focal brachytherapy. I would not be too surprised. But also I want to add one more thing. Sometimes if you have prostate cancer today, and then you are treated with external beam radiation only, and 5 years later your PSA comes back up, and they do all the tests and they figure out you only have prostate cancer on the right side of the prostate. This is a perfect time to do brachytherapy only on the right side of the prostate. When you give brachytherapy in a patient who have received prior external beam radiation, the toxicity is usually high. So if you can justify to treat half of the prostate, then this is what we do. We do have the prostate only in the setting of a patient who have come back, or where the prostate cancer came back after previous irradiation. But no other patients these days could or should be getting focal brachytherapy outside of a clinical trial.
Can I just follow up on that, Dr. Mohamad?
Yeah.
What about dose escalation when you clearly see a tumor on one side, it's localized, it's a high-grade tumor, and there may be some low-grade tumor on the other side. There is at least one guy doing dose escalation using seeds to what they call the index lesion. Do you have any
Yeah, we do that. We do that. It is not yet in a state, let's say it's not yet in a state of the art. With external beam, we can do really, really nice dose escalation. It's wonderful what we can do, the way we can do the dose escalation with external beam. With brachytherapy, we do that. Let me show you this picture. This is a good picture. It's not perfect, but this is a good picture. So let's say this is the green is your prostate gland, and let's say you have here a lesion that you know on MRI is aggressive and on biopsy. We can, during the planning process, we can dump a lot of dose in this area, such that the area that have the prostate cancer receives like 150%, 170% of the dose. We can do that, as long as it's not close to the urethra. When the cancer is close to the urethra, this is when our hands are tied. We cannot give you a lot of dose to the urethra because we will injure you.
When the cancer is in the transition zone, does that make it too close to the urethra?
Yes, but not necessarily. Sometimes the transition zone is very large. In patients who have BPH, the transition zone is very large, so it does not always mean that it is like on the urethra. But yeah, the urethra is in the transition zone. So if the cancer is on the transition zone, it's closer to the urethra than the cancer that's on the peripheral zone.
Okay. More questions?
Here,
Person in the back, go ahead.
is there a minimum size or volume for prostate you can do brachytherapy with?
Is there a minimum prostate size for
So yeah, for LDR, for low dose rate, yeah, there is a minimum, like, because think about it, this is your prostate, you are going in and you want to put seeds inside the prostate, and you don't want the seeds to be outside the prostate. If the prostate volume is very small, you cannot really implant that prostate well. Depending on whom you talk to, and depending on the level of expertise and level of comfort, that prostate volume for LDR is maybe 10, 15 cc's. But with HDR, you can implant these small prostates because. Huh? Sorry?
Go ahead.
With HDR, when you don't put the seeds inside, the 10, 12, 15 cc's are not very difficult to implant, as long as you don't have to put the seeds inside.
Okay. Another question?
Yeah.
Is there a limitation on the size of the prostate? Above 80 cubic centimeters?
Yeah. So again, this is all operator dependent. Again, for HDR, for LDR, for low dose rate, for permanent seeds, you don't want to implant something larger than, I don't know. And again, operator dependent, comfort zone of the physician, but 80 to 100 is considered too much, because, like, think about it, these seeds have to be spaced enough to cover the whole prostate. Then you don't want to be ending up to doing hundreds of seeds. But with HDR, you can push that limit a little bit more. I know doctors who have implanted with HDR, like prostates that are, I don't know, 100, 120 cc's in that level. The recommendation, the guidelines say the limit is 80 cc's, but also this is all depending on the operator, the doctor who's doing that.
Okay. Ma'am?
Do they need or give any sedation when they're inserting these 14 to 16 needles in radiation? Is there any sedation needed for the patient?
Dr. Mohamad, the sedation when these catheters are implanted?
So for LDR, because you are putting these needles, these seeds, you cannot risk, and you have to put the patient to sleep. because the seeds are very sensitive. You don't want what you don't want is to be putting seeds inside the prostate, and the prostate, the patient moves or kicks, and then you put the seed in the wrong place. If the patient coughs, basically you want general anesthesia and you want to paralyze the patient. With HDR, because you are not putting seeds in, you're just putting the needles, you don't want to do that. Unless you cannot do a spinal anesthesia or epidural anesthesia, then these are the only reasons where you do general anesthesia. I give you an example. I have a patient actually on Monday. We were doing HDR on them, but they could not stop coughing. They would, every time they cough, the whole ultrasound gets out of their anus, and you lose visualization. So eventually we ended up having to do general anesthesia to stop him from coughing. So every patient is different, and depending on the patient and on the technique.
Does the prostate cease to function after either one of these, either LDR or HDR?
Mostly the prostate tissue will die, and the function will be very, 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 very poor, if at all.
Okay.
So the job of the prostate is to produce a lot of the fluid that's in the semen, so that goes down significantly.
So as a follow-up on that question, can you talk a little bit more about sexual function after either LDR or HDR?
So the sexual function is among the things that is not very, very well studied in the treatment of prostate cancer. The main reason is that it's very, very difficult to measure sexual function. You can ask your patients all your kind of questions you want to ask about: can you maintain the erection? Can you have an erection? Can you maintain the erection? Can you maintain the erection for full sexual intercourse, etc.? But these are very, very subjective, so it's difficult to measure. The second thing is that the prostate, many of the patients, when we do prostate cancer treatment, they are in their 60s or 70s, so they already are at the point where their sexual function has either declined or is declining. So there are so many variables that are difficult to predict. But the thought process is, if in general, prostate radiation is gentler on the nerves than prostatectomy. Even with nerve-sparing prostatectomy, the general thought, and urologists may disagree, but there's lots of data. There's a paper published literally last week about quality of life after radiation, that in general, generally speaking, radiation as a group is gentler on the sexual function than surgery. Within radiation, there's general thought that the more compact you are in your delivery of radiation, the less sexual dysfunction. Meaning we think, but I don't know how strong the evidence is, that brachytherapy is better than external beam to prevent sexual dysfunction. But here I'm only comparing external beam only versus brachytherapy only. When you do both, it's another complication.
Okay, any more? Go ahead.
Does the brachytherapy affect blood vessels or blood flow that later affect blood flow to the legs, arterial blood to the legs? Does it affect the vessels?
Okay, blood flow to the legs. So let me add perhaps the lymph flow to the legs.
Sorry, what?
How does it affect blood or lymph flow circulation to the legs?
What circulation? I'm sorry, I cannot hear you.
Does it damage the arteries that supply the legs, or does it cause lymphedema later?
Lymphedema, you lymphedema?
Yes.
No, it should not.
Okay, what about damaging arteries, femoral arteries that take blood from the leg?
No,
it doesn't.
It should not. The radiation dose to these structures is very, very, very low from brachytherapy.
Okay. You know, one of the reasons, Dr. Mohamad, that I asked you to present tonight was to give you a chance to do a little PR, what we call, promote the HDR Brachytherapy that you guys do. And I think there are some unique features about how you do it at UCSF. And maybe you could talk a little bit more about that. For example, Dr. Shu does not use SpaceOAR, while other people do use SpaceOAR. Dr. Shu does what's called inverse planning. And so there are other unique features about how you guys do it.
Yeah. So the brachytherapy here in UCSF is actually very, very unique, and only Dr. Shu and those that Dr. Shu have trained do what he does. Basically, remember, if we started, let me go back here. You started. This is a template. Most places in the country, when they do brachytherapy, they put the needles for HDR. I'm talking only HDR. They put the needles through the template. With Dr. Shu, what we do, we don't use a template. It's a freehand technique. So we put there's no template. So it's a freehand. This is number one. Number two, yes, we don't use the SpaceOAR. We don't believe that the SpaceOAR is needed for this. The toxicity to the rectum is so minimal that we cannot justify putting the patient, putting like a material that is not that is gel. That with low side effects, but still we cannot justify the cost, for example, when the technique does not have a lot of side effects. So these are things we do here. The planning system that we do here was developed in-house, and now it is commercial, but the treatment planning is very special for UCSF as well.
And can you talk a little bit about the results? And is there some, from all these special techniques you use, do you see a benefit and outcome?
So this is the results. Remember, I told you this is the Dr. Shu's study 0321. They found a significant reduction in the toxicity compared to the combination study, the ASCENDE-RT. So this is why we think that maybe HDR is better than LDR in these situations, but it's difficult to tell because there has been no study to compare them head to head.
Okay, but still, what can a patient expect? I know that everybody's different, but let's talk about what we call grade 1 or 2 toxicity.
Yeah.
Especially acute versus long-term.
Yeah. So immediately after the treatment, almost everyone will have some side effects. Almost everyone. And the side effects: waking up more at night, urinating more during the day, some bleeding with urination, some burning with urination. I would say almost everyone. Now, again, most of the people will not have any severe side effects from that. They would not be severe. They're mild to moderate, meaning grade 1 or grade 2. Now, in radiation oncology, the way the doctor thinks about this usually is that we do not that we do not care. We do care about these toxicities, but we think about them as that we want to, treatment of cancer is not fun for anybody. And we think that we will do an aggressive treatment with reasonable side effects. And think about, very important, that the more aggressive the treatment, the more curative, probably not all the time, but the more aggressive, probably the more curative, and the more side effects from it. So we want to push for an aggressive treatment as long as we can guarantee that the patient will not have these long-term side effects, for a long term. So, for acute toxicity, where I'm saying like almost everybody will have some form of grade 1, grade 2. On the long term, the chance that you will have grade 1, grade 2 is probably like 20%. And the chance that have the severe side effects, which is grade 3, is 5%, as you see here.
And can you correlate the chance of long-term side effect with other features of the patient? In other words,
yeah. So if you start with a lot of urinary trouble, you will end up with a lot of urinary trouble. If you start with a large prostate, you will end up with with lots of urinary issues. If you start with BPH, you will end up with a lot of urinary issues. The older you are, the less healthy you are in general, the less active in your life you are, the more likely you will end up with issues.
So these statistics are somewhat skewed in the sense that they don't account for actual patient-to-patient differences, right?
Yes, for sure. But you cannot do these studies on small numbers. You need much larger numbers to really discern these characteristics.
Okay, but I think the takeaway for us patients is that treatment selection should account for these other
100%.
morbidities, right, or other features.
100%. This is what I started in the beginning. I started with patient selection, and if your patient have a very large prostate and he have lots of urinary symptoms and difficulty with urination, you should not do HDR. You should not do brachytherapy. The doctor should consider this and talk about all these considerations.
Okay. Dr. Mohamad, how are we doing on time? It's already.
I have to leave in 3 minutes.
In 3 minutes. Okay. Well, we have 3 minutes. Any more questions out here?
Except for that hip prosthetics, they can't do this on people with hip prosthesis. One of the slides. Or did they just not include those patients in the study?
Sorry.
Go ahead.
So for hip prosthesis, so this is a good question. So the hip prosthesis is an interesting question because it does not affect the radiation in general, but it's important because when we insert the needles, the patient need to have their legs in the dorsal lithotomy position, meaning like the position with the legs are hanging up in the air, like when females do pelvic exam. So if we cannot do that, then we cannot do the procedure.
Okay. All right. Well, if there are no other questions, I want to thank you very much for your presentation. I want to tell you, Dr. Mohamad, that I had a great experience. I'm very grateful to you and your staff and to Dr. Shu. I'm feeling much better 2 weeks after the procedure. And I'm looking forward to great control of my cancer.
I hope so. Did you start your external beam?
In a week or 2.
Okay, good luck.
Thank you. Okay.
You're very welcome. Thank you for the invitation.
Okay, thank you. Okay, bye-bye.
Bye-bye.
Okay.
Hey, Ethan, why did you choose not to have subject anesthesia? It seems like a particularly unpleasant procedure.
Oh, no. They give everybody a spinal, but they don't want to do general anesthesia because of the risk. So, and I asked them about that because if I had chosen to go down to a UCLA where they